Welcome to this video. I am Dr. Malak Tamasgan. Today we will see how to take a perfect obstetrics and gynecology history. I hope you will enjoy this video. Components of obstetric history. Components of obstetric history is almost similar to components of medical history despite some additional components. I decided to do this video to address such additional components in OBGYN history. So I will focus on history of present pregnancy, past obstetric history, and gynecologic history. The other components are well explained in my previous video on the topic of medical history taking. Among the components of identification, age and marital status are crucial in OBGYN history. The two extremes of age are indicators of high-risk pregnancy. For instance, a pregnant lady whose age is less than 19 has high risk to develop maternal anemia, cephalopelvic disproportion, and low birth weight baby. On the contrary, a pregnant mother whose age is greater than 35 has high risk to have a fetus with congenital anomaly. The other is marital status. It gives ample information on the financial support and emotional stability of a pregnant mother. A married pregnant mother is more financially fit and emotionally stable than an unmarried pregnant mother. So, knowing such financial and emotional constraints gives you the opportunity to arrest during antenatal care follow-up. History of present pregnancy. In the first part, you should know part index of the pregnancy. This includes gravidity, parity, abortion, live birth, and ectopic pregnancies. Gravidity. It is the number of previous pregnancies, including the current pregnancy, irrespective of site of pregnancy, duration of pregnancy, and outcome of pregnancy. So it includes ectopic and intrauterine pregnancies, molar and normal pregnancies, and pregnancies with live birth and stillbirths. Multiple pregnancy, like twin or triplet pregnancy, is considered as one gravidity. When you say gravidity, the mother has two previous pregnancies and currently she is pregnant. The other is parity. Number of pregnancies past age of viability irrespective of the outcome. Age of viability is the cutoff value for which a fetus can survive if it is born, and it is different from country to country because of their variation in their facility. The other is abortion. Loss of pregnancy before age of viability. If the mother has history of abortion, you should ask whether it is spontaneous or induced, whether it is first trimester or second trimester, whether it is safe or unsafe abortion, and history of procedures done, if any. Live birth means born alive, stillbirth born dead, either intrapartum or intrauterine. Ectopic pregnancy. It is extrauterine pregnancy. After knowing parity index, dating of pregnancy should be asked. Last normal menstrual period. It is first day of last normal menstrual period. Reliability should be checked to use last normal menstrual period for pregnancy dating. Last normal menstrual period is reliable when the cycle is regular, no history of hormonal contraception use, and presence of 3 regular cycles after discontinuation of hormonal contraceptions. Gestational age. It is age of the gestation in weeks from last normal menstrual period. Expected date of delivery. It is the date when a normal pregnant mother is expected to deliver, and it is 40 weeks or 280 days from last normal menstrual period for a menstrual cycle of 28 days. Around 5% of pregnant mothers deliver on EDD. The longer the cycle, the longer the expected date of delivery. So add cycle length minus 28 for longer cycle. For the shorter the cycle, the shorter the EDD. So subtract 28 minus cycle length from the EDD. Ovulation always occurs 14 days before the next menstrual bleeding. For a typical 28-day cycle, ovulation occurs on day 14. For a longer cycle of 35 days, ovulation occurs on day 21. For a shorter cycle of 21 days, ovulation occurs on day 7. In all scenarios, the red line, which represents luteal phase of the ovary and secretory phase of the endometrium, is constant, whereas the black line, which indicates follicular phase of the ovary and proliferative phase of the endometrium, is variable depending on the cycle length. Because we calculate expected date of delivery from day 0, as the cycle length tends to be longer, the EDD will be longer. As the cycle tends to be shorter, the EDD will be shorter. Calculation of gestational age and expected date of delivery. Gestational age is easily calculated at any visit by knowing the number of days from last normal menstrual period to the day of visit. A woman with her last normal menstrual period on September 10, 2016 Ethiopian calendar came for NC follow-up on January 20, 2016. What is the gestational age? To calculate the gestational age, subtract September 10 from January 20. We subtract the day from the day and the month from the month. Then 20 minus 10, it gives 10 days. 5 minus 1, it gives 4 months. Then convert into the same measurement, you will get 130 days. Finally, convert the days into weeks and it gives 18 weeks and 4 days. So gestational age is 18 completed weeks and 4 days. EDD is calculated by adding 280 days or 40 weeks or 9 months and 10 days on the last normal menstrual period. For European calendar, use Negress rule. EDD equals to last normal menstrual period plus 9 months plus 7 days. Because 7 months of the year have 31 days in European calendar. So we should add 7 days instead of 10. For Ethiopian calendar, EDD equals to last normal menstrual period plus 9 months plus 10 days. If it doesn't cross the year, or last normal menstrual period is on November 25 or before. If it crosses the year, or last normal menstrual period is on November 26 or after, EDD equals to last normal menstrual period plus 9 months plus 5 or 4 days. We will add 5 when Pagmen is 5. We will add 4 when Pagmen is 6. A woman with her last normal menstrual period on October 5, 2016 Ethiopian calendar came for NC follow-up on April 8, 2016. What is the EDD? October 5 is before November 25. That means it will not cross the year. So add 9 to the month and 10 to the day. Then 5 plus 10 gives 15. 2 plus 9 gives 11. Then it becomes July 15, 2016. Another example, a woman with her last normal menstrual period on December 17, 2016 Ethiopian calendar came for NC follow-up on June 10, 2016. What is the EDD? December 17 is after November 25. It will cross the year, so add 9 to the month and 5 to the day. When you add 5 to the day, it gives you 22. When you add 9 to the month, it gives you 30. Then transfer 12 months to the year and it converts the year 2016 into 2017. Then EDD will be on September 22. What if last normal menstrual period is unknown? There are different methods useful for pregnancy dating in case of unknown pregnancy, and the first one is ultrasonography. One of the major functions of ultrasonography is to confirm the presence of viable pregnancy and pregnancy dating. Ultrasound is preferred when last normal menstrual period is unknown, unreliable, and abnormally light last menstrual period because it might be implantational bleeding. Crown ramp length is maximum distance from the cephalic pole to the caudal pole. So crown ramp length is regarded as highly accurate in determining the gestational age in early pregnancy with plus or minus 5 days. After 14 weeks of gestation, the precision of crown ramp length decreases. Therefore, the 4 biometric parameters head circumference, biperimeter diameter, abdominal circumference, and femoral length are used to estimate the gestational age. As pregnancy progresses, the accuracy of ultrasound dating decreases because of the increased normal variation of fetal size and shape. Let's see the example. A gravidas reparatum mother presented to you on December 10, 2016 after referral from a health center for better follow-up as she is diabetic. She doesn't remember her last normal menstrual period, but she has an ultrasound result done on October 25, 2016, and the report says a singleton pregnancy and gestational age of 9 weeks. What is the gestational age and EDD? To calculate the gestational age, we use October 25 as a benchmark. At this time, the gestational age is 9 weeks. So, the gestational age is 9 weeks plus duration from October 25 to December 10. Then, gestational age is 9 weeks plus 10 minus 25 days plus 4 minus 2 months. As it is impossible to subtract 25 from 10, we transfer 1 month into the day. Then 40 minus 25 gives 15 days plus, as we transfer 1 month, the remaining is 3. 3 minus 2 months, it gives 1 month. Then gestational age is 9 weeks plus 15 days plus 1 month. When we convert into the same measurement, finally we got gestational age of 15 completed weeks plus 3 days. Expected date of delivery will be 31 weeks after October 25. So we will add 31 weeks on October 25. 31 weeks means 217 days. 217 days means 7 months plus 7 days. So we will add 7 to the month and 7 to the day. Then 25 plus 7 gives us 32. 2 plus 7 gives us 9. Then, as there is no 32 days of the month, we transfer 13 to the month. Then the day becomes 2 and the month is converted into 10. Then EDD is on June 2, 2016. When both menstrual date and ultrasound data are available, which will be used? American College of Obstetrics and Gynecology answers which will be used in case of discrepancy between ultrasound dating and last normal menstrual period dating. For a gestational age range from 8 plus 6 weeks or less, and the discrepancy between ultrasound and last normal menstrual period dating more than 5 days, it is preferable to use ultrasound dating. For a gestational age range of 9 completed weeks to 13 plus 6 weeks and the discrepancy more than 7 days. For a gestational range of 14 completed weeks to 15 plus 6 weeks and a discrepancy of more than 7 days. 16 completed weeks to 21 plus 6 weeks and the discrepancy more than 10 days. 22 completed weeks to 27 plus 6 weeks and a discrepancy of more than 14 days. 28 completed weeks and beyond and the discrepancy between ultrasound dating and last normal menstrual period dating more than 21 days. In this case, it is preferable to use ultrasound dating. The other method of pregnancy dating for unknown last normal menstrual period is date of quickening. Date of quickening is the first time when the mother felt fetal movement, and it is usually felt at about 18 to 20 weeks in the first pregnancy. And it tends to occur about 2 weeks earlier in subsequent pregnancies because of previous experience and abdominal laxity. To calculate EDD, add 22 weeks to the date of quickening in pre-gravid and add 24 weeks to the date of quickening in multi-gravid. The other method is date of fruitful coitus. We can use date of fruitful coitus if a woman can remember her single fruitful coitus, like pregnancy after a rape or couples working in different places with one occasion of fruitful coitus. The gestational age is literally age of the fetus because we calculate age of gestational age and expected date of delivery from the time of ovulation, not from day 0. So we add 266 to the day of fruitful coitus to calculate EDD. and it predicts expected date of delivery with accuracy of 50% within 7 days on either side. The last one is clinical examination, pelvic examination. In the early pregnancy, by assessing the size of the uterus, you can estimate the gestational age. Fundal by measuring the height of the fundus from the symphysis pubis, you can estimate the gestational age. Fetal heartbeat. Fetal heartbeat is heard with Doppler ultrasound starting from 10 weeks and non-electronic fetoscope with 20 weeks and HCG pregnancy test. Serum as well as urine HCG pregnancy test is positive starting from 4 to 6 weeks. So after knowing the gestational age at specific date, you can calculate the EDD from that. Until now, we have seen parity index and dating of pregnancy. Now we will see other components of history of present pregnancy. The other component is how was the pregnancy diagnosed? Because of missed period, because of urine test, or because of signs and symptoms of pregnancy. The other is antenatal care follow-up. Antenatal care is a health service provided to pregnant women. Ethiopia uses 8 contact ANC model for all pregnant women without complication. So while asking antenatal care follow-up, you should ask whether she started antenatal care follow-up or not. If she started, what was done. Antenatal care follow-up has 3 components: risk identification, prevention and management of diseases, health education, and health promotion. Basic ANC screening is investigations which are done for all pregnant mothers, include blood group and average, hemoglobin, screening for HIV, hepatitis B virus, syphilis, early ultrasound, and urinalysis. Selective or case-specific screening is done for pregnant mothers with specific risk factors. History of counseling on danger symptoms and signs. History of counseling on the importance of family planning, cooking, nutritional history, number of food items and frequency of meals consumed per day, craving for unusual food type, appetite and weight gain should be asked and assessed. Elaborate on the chief complaint if there is any. You should ask positive and negative statements. You should ask whether the pregnancy is planned, wanted, and supported. And you should ask history of counseling on birth preparedness and complication readiness. The other component is past obstetric history. It is the number of pregnancies and outcomes of each in a chronological order. Because some obstetric complications tend to recur in subsequent pregnancy, knowing past obstetric history is crucial, and it contains year of gestation, gestational age, whether it is preterm, term or post-term, place of birth, mode of delivery, vaginal, instrumental or cesarean delivery, birth outcome or birth weight, complications if any, including antepartum complication, intrapartum complication, or postpartum complication, whether the child is alive or not. Finally, we will see gynecologic history. The first one is menstrual history. You should ask age of menarche. Early menarche is associated with some gynecologic malignancies, and late menarche may be a sign of primary amenorrhea, and last normal menstrual period in case of gynecologic patients, and you should ask menopause. Late menopause is associated with some gynecologic malignancies, and irregularity of the menstrual cycle, whether it is regular or irregular cycle length. The normal cycle length is 21 to 35 days. If it is more than 35 days, it is infrequent and it is called oligomenorrhea. If it is less than 21 days, it is frequent and called polymenorrhea. Bleeding duration. The normal bleeding duration is 3 to 8 days, and if it is more than 8 days, it is excessive bleeding and called menorrhagia. Bleeding amount. The normal bleeding amount is 20 to 80 ml. Ask how many pads she uses, whether the pads are completely soaked, the presence of clot, and others. If it is more than 80 ml or excessive bleeding, menorrhagia. If it is light bleeding, we call it hypomenorrhea. Gynecologic operations. History of female genital cutting, any gynecologic surgeries or procedures and outcome. Sexual history, whether sexually active or not. Age of first sexual activity. History of sexually transmitted infections, including risk of HIV/AIDS. Contraception. History of use or need of contraception. Type of contraception, duration of use, and so on. Gynecologic history has 4 components. You can use the mnemonic MOSC. M for menstrual history, O for operations, S for sexual history, and C for contraceptions. This is all about obstetrics and gynecologic history. If you have any questions and suggestions, please write in the comment section. Thank you.